If you've been stretching, foam rolling, or even getting surgery for all your chronic issues and you're still in pain, you might be treating the wrong problem. In this episode, I'm joined once again by expert physical therapist Rick Olderman with over 30 years of experience and a brand new book out called Pain Pattern, where he breaks down chronic pain and how to solve them using systems thinking instead of conventional methods that they taught him in physical therapy school. We dive into frozen shoulder, neck and chest pain, and even get a little bit personal about my L5-S1 disc injury, which I've been doing great with. Rick made it even better just from this episode. If you've hit a plateau in your recovery and are just tired of Band-Aid solutions, stay tuned. Let's get into it. So before we start, I wanted to show you my SKOOL community I'm always talking about, but this is where I'm spending all my time. This is where I'm answering people's questions. We're brainstorming, doing coffee chats. I'll be starting a Q&A on Tuesday or Thursday, where basically I'm just giving out free personal training. First come, first serve. And this is the platform I'm trying to grow. This is where I want everyone to join who's over 40, looking at getting overall health, a lean body, and possibly some low-level biohacking. So if you're at all interested, get in while you can, and then we'll just grow from there. So other than that, let's get on with the episode. Rick, thank you for coming on my Over 40 Fitness Hack podcast once again. I know it's been a while. I want to tell my audience that we had a great session with your dancing skeleton you got back for us today, because it really helps with the visual. So, for my audience that can watch the video version on Spotify or YouTube, I'll have it there. But if not, do your best listening. But on our previous episode, I wrote some notes here that we talked about chronic pain and injuries, neck pain, mostly from shoulder blade and scapula issues, and lower back pain in general. And then also we dived into my problem, having a L5-S1 herniated disc and all the stuff that I've been going through. A lot of the stuff that you had me do for my lower back has been great. I've been walking around with my knees bent, focusing on that because that was a big thing you had. And also some different exercises to help stretch the quads, not just the hamstrings. I wanted to talk about some of the new questions my community members had, but maybe before we start into that, just a quick recap of how you got into what you do. Anything else you want to throw out there before we get into some of these questions?
Sure. I've been an orthopedic physical therapist for almost 30 years now. Earlier, I found that I wasn't very good with helping people with chronic problems. So that's why I decided to look a little deeper. That's how I came up with this whole approach, which is more of a systems-based approach that addresses the body as interlinking systems and understanding where stresses from further away cause problems at different places. We're not trained to think this way in medicine, even in physical therapy school, which seems like this is exactly what physical therapy school should be like. It's definitely not how we're trained to think. And most people are left with these component thinking diagnoses. Oh, you've got rotated vertebra, or you've got, earlier today, I talked to someone who said they were diagnosed with a weak multifidus muscle. Well, I'm sorry, you cannot isolate a multifidus muscle. It does not work in isolation in the body. So these are the types of diagnoses people have that they believe are the cause of their problems. But really what's happening is there's a systemic breakdown in the body, usually from older problems that they were unaware of, that then cause vulnerabilities where they're feeling pain.
Yeah. Well, I know the whole kinetic chain starts from your feet, working its way up, and there's just a multitude of things and checklists of, like we just mentioned, keeping your knees bent while walking. It seems like you wouldn't have to tell someone to do that, but it does seem like almost everyone leg locks while they walk. It's just simple movements and patterns that over time cause all these chronic issues and the transference of pain when the problem is a foot away down your body.
Yeah. And so I just published a new book called Pain Patterns. Over the course of my career, I've identified 3 primary pain patterns that are behind almost all spinal pain. And almost all 3 of those pain patterns are due to problems in the lower body system. There are lots of different names, transference and other things like that, but really it can be very simple once you understand how all of these things fit together. Solving pain is very simple.
No, that's great. I'll definitely put a link to that book in the show notes. Well, Rick, let's get down to some of the questions my community members were interested. First one is just frozen shoulder in general. I remember having clients back in my 20s that had this problem, and I don't even know at that time any of them ever got any fixes. Even the steroidal injections didn't seem to do well. It seemed like maybe 1 out of 10 got any real benefit without having the full surgery, which is also not great because then you don't ever get that full range of motion back. What are your thoughts on frozen shoulder now? Do we have any better science? Or
frozen shoulder follows a spectrum of hallmarks. And so early frozen shoulder in the first few months, there's really not many treatments that will stop this. So you really have to kind of let frozen shoulder take its course. Because we don't understand why it's happening, we can't really understand how to solve it. And so typically if I receive a patient who's, let's say, oh, I've had frozen shoulder now for 3 or 4 months, I'm saying, come back in a couple months, because it still hasn't run its course yet. And I'll give them a couple exercises to try and maintain range of motion, but putting your effort into those early stages of frozen shoulder, trying to increase your range of motion is really just going to cause a lot of pain and frustration. The effort should be trying to not lose as much as you possibly can. So you just have to have this mindset that my shoulder is going to reduce range of motion over these next few months, and I'm going to do my best to limit that. And if you can be in that mindset and keep your sanity, then I think you're doing well. And the next phase of the frozen shoulder is where you can start to perhaps climb out of this. And so I prefer to see people after 6 months of frozen shoulder, then we have something to work with, because I'm not trying to fight a disease process that no one understands in the first place. One of the things that I've found that is helpful in that second stage of frozen shoulder is class 4 laser. I don't know if you've worked with one of these before,
like
Brad.
red light?
Well, red light is not necessarily a class 4 laser. That's just a type of laser. And class 4 is the strongest class out there. It's a 15-watt laser. And most lasers are level 3 or 2. They don't have the wattage of a class 4. I have found significant improvements in frozen shoulder and other chronic issues marked by lack of range of motion. Like even if you just had shoulder surgery and you can't seem to get that last 20%, that laser seems to really open up a lot of fascial restrictions in the shoulder or other joints in the body. And I later learned that class 4 lasers in particular trigger a release of nitric oxide in the body. Nitric oxide is a naturally occurring gas in the body that is involved with blood, dilation, blood vessel dilation, nerve transmission, things like this, blood pressure reduction. And so what I think is happening is that the class 4 laser in at least a frozen shoulder situation is causing this nitric oxide production locally. And researchers also pointed to the fact that fascia relaxes in the presence of nitric oxide. That's how I think the laser is helping people with frozen shoulder in these later stages. It won't really help that much in the earlier stages, but the later stages after the disease process or whatever process it is that it's gone through, then you can start opening up that shoulder with the laser therapy. And the treatments I've had, not all of them are dramatic, but many of them were. So it was very hard.
Okay. Well, I know my community member mentioned that so far massages seem to open up a little bit more, obviously not solving the problem. It doesn't seem like, and just from clients in the past, I remember seeing some of the MRIs and seeing some of the scar tissue around there, which is why they want to go in and start cutting and doing their stuff. But right now it seems like the best you can do is just manage it and work through it.
But you got to wait it out until you get to those later stages, and then you're working with a shoulder that you can do something with. Aside from laser, the other thing, if you're going to be targeting the shoulder manually, it's really important. What I've noticed is a lot of practitioners focus only on the arm range of motion of the shoulder. They're not focusing on the scapular motion of the shoulder. You'll have someone saying, oh, how far can you get your arm up? Oh, you can only get it. Okay, well, let's stretch it so you can get it up to here. But really the reason they can't get up is because a big portion of that motion is coming from the scapula that needs to rotate underneath the arm motion and elevate, which then opens up the whole shoulder joint to be free to move overhead. And so what I find with a lot of shoulder, it's not necessarily just frozen shoulder, but also anyone who's had shoulder surgeries or chronic shoulder problems, the scapula has adhered down to the rib cage through spasm or fascially. Loosening the shoulder blade from the rib cage has helped significantly with range of motion for these people.
Maybe in my member's case, maybe that's what the massages are inadvertently getting some motion in that scapular range. So
yes, I've been to a few massage therapists, but I haven't found anyone who's actually
gone under and
lifting the shoulder blade off of the rib cage. Because can you get in there and actually lift it? And I don't find many who might slide their fingers underneath it a little bit, but I think people are worried. I had this one federal judge I was treating who had rotator cuff surgery and his shoulder was stuck. I got underneath his scapula and actually lifted him off the table by his scapula, pulling it from his trunk. He looked up at me while I was doing this and he says, "You do realize I'm a federal judge, don't you?"
I am being very careful here.
Yeah, I realized that. And he got up and lo and behold, his arm could move like it hadn't in over a year. The scapula is critical to restore motion. The shoulder blade, like pelvis, is the center of biomechanical function. Same goes with the shoulder blade. They're both broad bones. This shoulder blade needs to rotate 40 to 60 degrees up as you're raising the arm up to open up that joint space in the shoulder joint. And if that's not happening, your shoulder is just bumping into bone here. And that's what is irritating the shoulder and causing the lack of motion people are suffering from.
Yeah. Definitely a lot to unpackage there, somewhere to start at least. So the next member was talking about chest pain, thought it was the heart when it's dead center. They threw out there maybe it's I can't even say this, costochondritis syndrome or something with the sternum causing the pain and the muscles attachments to the sternum. So what's going on there? Let's unpackage that one.
Yeah, this is a really unusual one. Frankly, I've never treated someone with costochondritis syndrome. It's important for your audience to know that itis in medicine just means inflammation. That's it. Tendinitis, costochondritis, bursitis. It just means that something is irritated. Costochondritis means that the junction between the cartilage and the sternum is irritated. And it was interesting because I have never even treated someone with Tietz syndrome, like what you described in the email. So I had to look that one up. And that's even more specific.
Oh, wow.
So Tietz syndrome is that this person suffers from. It involves just the top 3 or 4 cartilage interactions with the sternum. That's very suspicious. There are some muscles inserting roughly here. The pectoralis minor that inserts from the shoulder blade into the chest. It doesn't insert at the junction of those cartilage muscles, but it inserts into the 2nd, 3rd, and 4th ribs, which are then irritating at the sternum. So I immediately am wondering, does this person have a pectoralis minor problem? Maybe they have a loose junction, like some people are hypermobile, right? So maybe he has loose cartilage at the junction of his ribs and sternum. And so the pectoralis minor is therefore putting pressure on the ribs, which is irritating their insertion into the sternum. I don't know, but that's one of my thoughts about what may be going on. According to the research I did on Tietz syndrome, there's nothing you can really do about it. You just have to take painkillers and wait it out. Usually in a few weeks, it'll go away.
Okay.
So if they've been waiting several weeks and they've tried painkillers and anti-inflammatories and that hasn't worked, to me, that's signaling that this is likely a mechanical issue. Those cartilage are inserted into the sternum. And the thing that I can think of would be the pectoralis minor.
Okay. So maybe you start working on that. That relieves the pressure off the 1st and 3rd cartilage inserting into the sternum. And maybe that's what's going on.
That would be my first thought. And that only occurs if they've gone through the period of time where this should have resolved on its own, because it does spontaneously resolve on its own, according to what I read. If that hasn't happened, then likely there is a mechanical issue going on. There are other things that can also contribute to this. I'm sure if we went into this last time, Brad, but I talked about a side bending problem where one side of the rib cage is resting too low.
I don't think we did.
Okay. This is often at the root of one-sided back pain, sciatic pain, and is usually caused by a problem in the lower body system. That's an asymmetrical problem that causes the body to respond by elevating the pelvis on one side. The muscles that elevate the pelvis attach to the rib cage and pull the rib cage down. So if they also have an older problem on the same side as that costochondritis or Tietz syndrome, that even lends more credibility to this being a biomechanical issue. For instance, if they have chronic knee pain on that side or chronic sciatic pain or SI joint pain, likely they'll have a side bending problem that is then contributing to the distortion of how the rib is inserting into the sternum. So that would be another thought of mine. Or if they happen to have an old shoulder problem that is occurring on the same side,
could be pulling.
Well, a lot of old, right, exactly. The shoulder, when we have pain in something, usually it adheres down and stops movement, to protect it. And the pectoralis minor is one of those muscles that adheres down in the case of an old shoulder issue. So that's how I would think about it from a more systems standpoint, rather than just the diagnosis. Here's the problem right here. No, that's where the pain is, but that may not be where the problem is.
So definitely after a few weeks of seeing most things, wait a couple weeks, it's chronic pain until months later. If not, then go the next step. And it sounds like he needs probably some hands-on physical therapy to check all those other points you just mentioned.
Yeah, most physical therapists may not even look in those areas, but I think that would be the logical next step, because they'll at least assess the shoulder joint. Maybe they'll assess the shoulder blade and think about that pectoralis minor. So you have a good chance of some of that happening. And that would be my next step there as a biomechanical cause of this. It would help them if they can say, oh, well, that reminds me, a year ago, I had shoulder surgery, or I dislocated that collarbone, or I've had this chronic sciatic pain on the same side for the last 6 months or 12 months. That means that likely there may be a link here biomechanically that you haven't considered yet.
Is that something that you can diagnose through Zoom? Obviously, not everyone through my audience can get a hold of you locally. Is that something you can catch through Zoom and their own measurements with you?
I can assess most of that through a Zoom session. I can't assess the pectoralis minor specifically, but I can look at the shoulder system, their rib cage and the pelvic region, and do a lot of testing to see if there are problems that may be feeding up the chain into that area.
I will let him know. All right, let's move on to the next one. The next one was shoulder and neck pain. I remember the member mentioning that not much info. I think we've even talked about it, which is fine. We can talk about it again. But it was more interesting the fact that he mentioned raising up one arm and having pain on the other side. So what do you think about that?
That's a peculiar symptom. There are some muscles that attach from the shoulder blade into those neck bones. One of those is the levator scapula, and it's a deep muscle in the shoulder blade, and it attaches from the corner here up into C1 through 4 or 5. And so what I'm wondering is if the right scapula is not functioning correctly, if it's not working well, then what often happens with that levator scapula is it will act on the cervical vertebrae. That will often lead to radicular symptoms like nerve symptoms down the same side, neck pain or headaches. But in this gentleman's case, he may have a hypermobile cervical joint that, because the levator scapula is pulling on it, is now causing that to irritate the other levator scapula that's leading down the other shoulder. Hopefully someone has assessed the cervical vertebrae, because this indicates a hypermobile or some problem with the cervical vertebrae. But really, why would that cause a problem? Well, you have to fix the connections from the shoulder blade into the neck first to remove the stress. It's not the cervical vertebrae's hypermobility that's a problem. It's the excessive stress coming from this levator scapula that's moving it that is the problem. But that would be my guess as to what's going on there.
So just staying on neck pain and headaches in general, even though we talked about it last time, it seems like most of the issues start with assessing the scapula and all the issues. Is there ever any problems with the trapezius going up there and the other muscles? That is the issue, or it almost always comes down to the scapular feeding into that and then back up. It's just all a kinetic chain, right?
Okay. It is. And so the second part of your question is the correct one, that if the trapezius doesn't act alone, it's attached to the scapula, right? So if the scapular function is wrong, then the trapezius is going to be wrong, or the levator scapula is going to be wrong. But I tell you, Brad, I can't think of the last chronic neck pain, headaches person I saw, ridiculous symptoms, all of it. Then it wasn't the scapula fault. It's really the center of function. So just like the pelvis.
And that's something that people can take care of themselves with exercises. I know you have videos on your website, because I'm sure there's a whole slew of videos that all of us should be doing just as protocols throughout the week that we could all help ourselves from the ankles up, right?
Yeah, I think so. And it doesn't have to be a slew of videos, but there are things that you can do. For the guy who had opposite pain on one side of his shoulder, one really simple exercise is to get on your hands and knees. Your hands are on the floor, your knees are on the floor, and you just sit back on your heels. And what that's going to do is it's going to stretch the arms up over your head. The most common problem with shoulder blades is that they are resting too low. It's called depressed scapula. This simple exercise will stretch the muscles. Often, this is what I would do in the clinic. I'm thinking this is a depressed scapula thing after looking at all this testing. So we're going to give you a little test to do that. It's a very gentle stretch. Feels good for most people. And then I have them get back up and now move your head around or raise that right arm around again and see if you still have pain in that left shoulder. Most people, this is how quickly I expect a result, is that I should get immediate pain reduction if I'm doing the right thing. And so this person could do this stretch. If they do this stretch and they feel no left shoulder pain, then that's telling you that there's got to be something biomechanically going on here. Does that make sense?
This is so crazy, because in the world of physical therapy, just like when I first had you on my show, you're like, they don't teach you this when you're going through your stuff. Just like we don't even have a personal training school. We just have certifications either online or in person. Yeah. I'm 20 years in, maybe 10% of that is useful information to me today. It's all the stuff I've learned just talking to people and just experiencing life.
Yeah. By the way, I have created an online training program for physical therapists, personal trainers, yoga instructors. I feel anyone who deals with movement in the body, coaches, doctors, nurses, massage therapists, should understand how the body works as a system. And so that's this training program. That's also on my
very
website.
Cool. Definitely interested in that. I'll check that out. So Rick, one last thought. I'll put selfishly on myself with my issues with my L5, S1 herniated disc. I've had 2 surgeries. It took 2 to get it all. Been doing great with all my protocols. I walk with my knees bent. That really helped. And thank you for that. What you gave me was lying on my back, holding my knee up. I ended up doing that a little too hard and pissed everything off, which also do aggressive. But I found that anytime lunges, the exercise I mentioned, anytime my 2 femurs go that far away from each other, I feel like it puts a torque on that L5S1. Adopted the theory of don't let those femurs get too far away from each other. Everything has been great. I started doing Nordics to get it. I still realize the quads are the issue for me. So I started doing Nordics, and those ended up doing great. So for my immediate problems now, I feel great all day. It is literally sleep that is the problem. I have orchestrated my sleep with a pillow between my ankles and knees. I realize that on a normal mattress, My shoulders are wider than my hips, so I pulled my mattress pad down lower than my shoulders so my shoulders would have an extra inch or something. That helped.
Good for you.
I'm still like at 85%, and it only takes me 5 minutes to warm my body up in the morning where I feel 100%. But is there anything else to do to enjoy sleep? Because some of these issues will still wake me up in the middle of the night.
What positions are waking you up? What position are you in when it's painful?
I would say on my back with a pillow below my knees, best, but it's not my favorite position. Always fetal position on left side.
Yes. So what it sounds like you're confirming to me is that you have an extension problem, which means that your back pain increases when your back arches.
Yeah, I don't know.
Well, if you prefer to sleep with a pillow underneath your knees, that is flattening your spine.
Okay.
Does that make sense?
I kind of justified all of this by having my wife look at me when I'm on my side. She fixed the pillow to pull me up to the level and all the other things I mentioned to make sure from a side view that my spine looks straight all the way across. Since doing that's what I'm saying. I've had great success. I'm just trying to get that last little 10 to 15.
But you mentioned that unlocking your knees has helped and stretching your thigh muscles.
And do that before I go to sleep. And that's helped. But
right. So what those two things do are reduce the extension forces acting on your spine, right? Because when your knees are unlocked, then your pelvis isn't anteriorly tilted, which is then causing the spine to arch excessively. By stretching your thighs, you're also removing that anterior tilt stress from your spine. And you said that when you sleep on your back, you like to have a pillow underneath your knees. That also helps your back, correct?
Yeah, but also from our last talk, you told me to do it anyways. It just relieves the pressure. Yeah.
Right. You still have extension stresses acting on your spine, even while you're sleeping. So what I've noticed, what a lot of people do, even when they're sleeping on their side, is they tend to arch their backs.
Oh.
Even with their hips flexed. It's a stress response. So you're sleeping in this fetal position, but your back is arched like this because it's how you to do things.
So what should I be doing? A pelvic tilt?
Well, first assess whether that's actually happening. And then rather than doing it aggressively the opposite direction, what if you just didn't do that?
Just went neutral.
Stop doing that and see if that helps. If it does, then you realize, oh, okay, this is a habit stress response I've developed because of all of these forces during the day that are causing my pelvis to anteriorly tilt and my back to be too arched. My back has habituated by contracting those muscles because of these behaviors. And I'm not able to turn that off at night, right? And so have we talked about hanna-somatics, Brad?
I don't remember.
Okay, so hanna-somatics, Thomas Hanna studied neurological reflex patterns and their role in chronic pain. And breaking patterns of habits like what we're discussing right now, hanna-somatics does a really good job because it reintroduces your brain to the area that is unconsciously contracting. And it teaches you how to break that. But I can show you how to do that really simple. I have some hanna-somatics programs in my home programs and then also in this new book that I wrote. But basically, if you're sitting down right now, right? Okay, so if you just arch your back, you'll feel the contraction of your low back muscles. Now, slowly release the contraction. Try to control the release of that contraction, allowing your back to move into some flexion instead. All right, and then you repeat that 2 or 3 times. What you're doing is getting your brain to connect with those low back muscles that are unconsciously, habitually contracted. And you're teaching your brain to consciously monitor them and learn how to release the contraction you're unconsciously holding. The key is that you are lengthening the muscles by flexing the spine at the same time to allow that to happen. And if you do that before you go to bed, let's say you get into bed and you do 3 or 5 of those while you're on your back or on your side, and you learn how to consciously release and lengthen those muscles and then just relax there and go to sleep, we'll see if that is helpful for you.
And once again, that's just going to a neutral position. You're not necessarily trying to arch it completely pelvic tilt.
You can take it into a pelvic tilt at that point.
Just do it slowly.
Because you're lengthening the muscles, but you don't want to stay in that pelvic tilt, right? Because nothing likes to be excessively lengthened.
Then I'll have to start having different problems.
Exactly. From a somatic standpoint, they're not interested in taking you through the full joint range of motion. They're just interested in releasing the tension that's holding that joint in a restricted range of motion. That doesn't require you to overly lengthen things. But in the case of the back, because it's so articulated and is able to go into some flexion, you might as well try to take it into a little bit of flexion and see if that is okay. With disc issues, flexion increases disc pressure. So you want to be careful with how much flexion you go into with that situation.
And when it comes down to it, I have a crushed disc. This is always going to be a continuing problem unless I do something. But I've done so great with my routines, my stretching, what I do in the gym. This was just, man, if I can just keep this going. If I do have to end up doing something like a disc replacement, hopefully it's in my 80s. I don't have to deal with this right now. So
So I'm curious, Brad, are your thigh muscles still tight?
the quads are always tight. And as much as I try to remember it and put in my routine, do my Nordics, all that, it's a constant battle to do that. And when I do stretch my hamstrings and stretch my quads are so much tighter all the time than my hamstrings.
So this is why separating your legs is still causing your back issues. Because when one leg is going back, it's causing excessive extension forces in your back, and that's what you're not liking.
So how much stretching do you need to do to get these quads to stay loose?
Yeah,
I do this every other day, and it just seems like it's not enough.
Yeah, I agree. And so this is what makes me curious about why your quads are so tight all the time. Is this a stress response to work? Are you one of those big exercisers where you're always working your legs?
Not really.
All right. So if you sit in a chair all day long, that shortens the quads. But there are people who sit in a chair all day long and don't have tight quads, right? So, my feeling with people like you is that if you're stretching the quads, it's a perfect idea that you're stretching them before you go to bed. I think you're absolutely right about that. Yeah. So, but I wouldn't drive yourself crazy to say, I've got to figure out how to keep these permanently lengthened. Clearly, they're not going to be permanently lengthened. Sometimes we just have to live with how we're built and understand it. You're doing the best you can by stretching whenever you can, especially before bed, to offset that reality. Don't beat yourself up. Just do your best. It's already clearly worked well for you. It's like if I had an old broken toe that I knew I had to walk a particular way on. That's just the way I have to walk on that toe. And that's the way you have to deal with your quads.
No, and I understand that, but I'm just always trying to get that. If I can get an extra lid,
I know.
But,
I have nothing more for
we're
you
fragile. There's no way we can.
We're humans, and we're all built differently, and we all have tighter or weaker or longer tendons, shorter tendons, longer ligaments, shorter ligaments, stress responses, personal histories of sports, exercise, injuries, all sorts of things, psychological trauma. All of these things play into how we present. And so we're all different in that regard.
Absolutely. Well, Rick, I just want to thank you again for coming on my show. We know about your new book. I'll put that in the show notes. I think that's great. Definitely didn't know about any physical therapists or personal trainers listening to my show, including myself. That'd be excellent to, get some type of certification or just knowledge, stuff that we can do to help our clients. Obviously, if they're having real issues, we need to get them professional help, but at least something we can do in the meantime. Is there anything else you want to throw out there to my audience?
The new book I have out is called Pain Patterns. And what I really like about it is it goes into the systems thinking. It shows the systems in the body that, are behind chronic pain. The second half is a workbook. You fill out the book, test yourself, and see where your problems are. I've also created videos of the tests and the exercises to correct those problems on my website. I think it's a real game changer. If you're looking for something different than what you've done before, and what you've done before isn't working for you, this is likely where you're going to find a whole new perspective about how we function as humans.
So that's awesome. Having something that you can test yourself on as you're going through this book. And you may discover something you didn't even know was an issue by failing one of your tests. I mean, that's huge to get that info. So
I can almost guarantee it. If you're dealing with chronic pain, it's because you haven't uncovered something that someone hasn't tested yet. Because I believe that there's a solution to almost all chronic pain out there. If you have chronic pain, it just means that your previous practitioners aren't looking in the right places. Usually it's because we're not trained in systems thinking. We're trained in component thinking.
And you know what, just like all the different modalities out there that people claim solved all their problems, and I believe they do, just like your level 4 laser you talked about. I have heard people using that for spinal stuff and doing great. But the problem is if you don't take care of the structure that keeps putting you back in this, you're just going to be burning your money up having to get these modalities to constantly fix you.
You're absolutely right, Brad. Speaking to the choir.
Well, Rick, I'd like to thank you for coming on again, and I'd love to keep getting you back in every now and then.
Anytime.
When you have something new. So,
yeah, as long as you're not bored with what I'm saying, I'm happy about it. I love answering people's questions, and whenever you want me on, I'm happy to come back.
Absolutely. Appreciate it.